This is Dr. Dreyfus from Paris, France, and I spent a couple of years in Switzerland to have my MD PhD degree.
I see.
The French part, so I can speak a little bit Francais.
Ah, you speak French, so that's
Bonjour,
good.
enchanté, comment allez-vous? Yeah, today is the AATS, and yesterday we heard a lot of argument about the open surgery and the minimally invasive surgery, and Dr. David Adams don't care about the minimally invasive, but patient themselves, they want the minimally invasive surgery. So in your opinion, for the mitral valve repairment, it makes difference between open surgery and minimally invasive surgery for the life quality or the long-term result?
Well, I think that not only David Adams, but I think you heard the talk of Mark Gillinoff from the Cleveland Clinic,
Yes.
who really said that the incision was not the aim. The aim of mitral valve repair is to repair the valve. If you can do it minimally invasively with a good result similar to a standard sternotomy approach, fine. The problem is that patients, they see advertisements and they are told that minimally invasive is less invasive than sternotomy and things like that. But the real aim is, do you want to have a long-term good results for your lifetime with something like 4 or 5% reoperation at 15 years and 20 years? Or do you think you can be submitted after 4 or 5 years to the need of reoperation? This is a problem. I don't say that minimally invasive is bad. It has to be done properly. There is no shortcut in the surgical technique.
Yes, and I see you show some very nice video repair the mitral valve with the达芬奇system. So which kind of patient you will choose, the open surgery or the达芬奇system?
I did robotic, and with the robot I can do the same as I would do with the median sternotomy. But you know, I did Barlow's, I did papillary muscle repositioning, resection. I think as long as you don't have aortic regurgitation, as long as you don't have peripheral vascular disease and annular calcification or leaflet calcification, I think robotic you can do nearly every case. So what I do choose is usually, funny enough, the young patient, they tend to recover quicker with minimally invasive and robotic surgery than the older patient. The older patient, they have all the complications. Yes. They have pleural effusion, pericardial effusion, arrhythmia, all of this. So these patients, you know, they have pain, you need to give them painkiller, whatever. The younger patient, they do recover better. So I tend to choose straightforward indications of mitral valve surgery.
And I found that you are very open-minded. That's because some surgeons, for example, not only open surgery or the minimally invasive surgery, but for the technique to repair the mitral valve, some insist that respect rather than resect, and they never resect. And some of them,
I think it's wrong.
Yeah.
I think it shows. Again, as I said to the guy who presented this morning, why do you oppose resection, non-resection, or resection to Gore-Tex cord? This is a mistake in your. It's a misunderstanding of the lesion. If there is excess tissue, I don't know if you saw a presentation by Wu from Stanford yesterday. He had a SAM on a posterior leaflet which was more than 3 centimeters high. Why do you not want to resect them? You can resect transversely the valve and then use Gore-Tex cord to suspend the free edge. But I mean, I'm against, you know, dogmas. You resect when you need, you don't resect when you don't need.
yes.
There's no war.
Yes, cold day or the resections are weapons for us.
Yeah,
But how about the edge-to-edge technique?
No, I really think, you know, I have never used edge-to-edge.
So do I.
And I've been asking, I didn't want to ask because he's a young guy and he was presenting data. But I mean, the penetration worldwide is not increasing.
Okay.
There is a reason.
Okay. Thank you for your time. Merci beaucoup.
Thank you.
Merci
Thank
beaucoup.
you.
And welcome to East Hangzhou.
Yeah.
I will send you a mail.
Hey, let me take a picture of your
From China.